Hello, I'm Maurice Mommaerts, and I welcome you to a crash course on total alloplastic customized TMJ replacement. It's 9 o'clock in the evening here in Belgium. 282 persons have registered. And for those missing out today, the same webinar will be held on the 17th of May. For your convenience, the webinar will be recorded and at your disposal after the session. The majority of my TMJ replacements are carried out at the University Hospital in Brussels. The course is meant to encourage you to perform your first total joint replacement. This webinar is meant for those experienced TMJ surgeons interested in treating end-stage disease using patient-specific implants. I will not deal with extended jaw replacements, muscle reinsertions, or anything beyond a simple total joint replacement. I disclose my co-ownership in CAPSULE, a Flanders-based company focusing on customized implants. This is the plan for the next 30 minutes. We will discuss data, image acquisition, and the components of the prosthesis, indications for coronoidectomy, explain types of access, and proceed step by step on a model and in video fragments of a surgical intervention. A CT scan with MARS protocol in case of metallic inclusions is preferred to a CBCT scan. MARS stands for Metal Artifact Reduction Software. The dentition should be in maximal occlusion. When occlusion is corrected simultaneously, orthodontic surgery, then go for centric relation. A copper wax bite or a vinyl polysiloxane bite registration can help when the image acquisition can be performed locally and quickly after the bite registration. The field of view should contain the maxillofacial complex and ask for submillimetric slice thickness and for a cloud-stored DICOM dataset. Okay. Only when occlusal corrections are aimed for is the accurate occlusal morphology made available through high-resolution CT scanning or optical scanning. Every company provides written guidelines for the image acquisition. The patient-specific components are the mandibular component, made of 3D printed titanium with a CONDYLAR head coated with HATSAT. The FOSSA component, made of 3D printed titanium and highly cross-linked ultra-high molecular weight polyethylene containing tocopherol. 3D printed cutting guides and 3D printed dummies in NextDent surgical guide polymer, of which I personally use only the FOSSA one. It is important during the planning of the case to know if the contralateral joint will collaborate, but also if the coronoid process will not hinder mouth opening. There are two image-based diagnostic tools to check coronoid hyperplasia, whether it's absolute or relative. The first is by looking at the panorex view. Eyeball horizontal lines touching gonion, line 2, condyle, line 3, and the tip of the coronoid process, called KR here, line 4. If the distance between line 4 and line 2 is 10% larger than the distance between line 2 and line 3, then chances are that the coronoid process will block mouth opening if not resected. This is the Lewandowski analysis. Another tool is CT-based. Normally, the length of the coronoid process is 20% shorter than the condyle, than the length of the condyle. In case of doubt, I recommend you to resect the coronoid process, but please check both sides. Let's discuss accesses. I used images from the AO syllabus and from Ed Ellis' book. Important structures to consider are the facial nerve and some branches of the external carotid artery and internal jugular vein. The vertical ramus is approached via a submandibular or retromandibular incision. Let us consider the submandibular incision first. It can be parallel to the mandibular border or within a skin wrinkle. The lower the better in relationship to the marginal branch of the facial nerve and for access to the external carotid artery in case it needs to be ligated. The more cephalad though, the easier to insert the mandibular component and insert the osteosynthesis screws. One has to outweigh advantages and disadvantages and decide. As for the length of the incision, one can always start short, like 3 cm, and pending elasticity of the soft tissues, extend anteriorly. Slide a hemostat under the platysma and cut it at the same level or lower. There are some nice publications about the location of the marginal branch and vessel structures in relationship to the mandibular border and gonial angle. First, know that the facial artery is in front of the facial vein. Remember the letter A, artery, is the first. And also remember that the facial artery is more tortuous. You can encounter it many times. What to remember from these publications? Usually the lowest point of the marginal branch, being 5 mm below the mandibular border, is to be found 1.5 cm in front of the gonial angle. And the marginal branch transects the mandibular border, usually 4 cm in front of the gonial angle. One can elevate the marginal branch en bloc with the superficial cervical fascia and the platysma muscle and push the vessels anteriorly, or one can identify and ligate the vessels. The next step is to incise the pterygomasseteric sling down to the bone and split the parotid gland posteriorly. The masseter muscle is not easy to disinsert. However, this should be done carefully as not to leave any intervening soft tissue between the cutting guide and or the mandibular component and the bony surface. The lateral surface of the vertical ramus should be dissected up to the joint capsule and the temporalis muscle insertion. When pathology is confined to the condyle and the soft tissues are thin and elastic, a transparotid retromandibular approach may be chosen. This mass is incised and the parotid gland gently spread using a hemostat till the masseter muscle is encountered. Many surgeons don't like this approach because of the vicinity of the buccal and marginal branch of the facial nerve. Also, the retromandibular vein and the greater auricular nerve are to be considered. The masseter muscle is incised, disinserted, and again subperiosteal dissection performed up to the capsule and the insertion of the temporalis muscle. The submandibular approach lets us expose all of the vertical ramus. One can extend incision anteriorly to access even the symphysis and even the contralateral horizontal ramus. Besides the transparotid, there is also the retroparotid, Biglioli Coletti, so-called mini retromandibular retroparotid approach. I've used it for TMJ replacement, but I do not recommend it. When you start out, use the submandibular, so-called Risdon approach. However, a mini retromandibular approach may result in quite unnoticeable scars. Pathology and resection height, soft tissue thickness, elasticity, and previous incisions help to determine the choice of the approach, most notably the length of the submandibular incision. The osteotomy guide, made from unbreakable titanium, is inserted and stabilized using 3 screws, inserted via the submandibular approach, whereas the condylar resection itself is performed from a preauricular approach or a temporal approach. This brings us to consider the course of the frontotemporal branch. The safe zone for any access incision is posterior superior to an arch with the lateral canthus as a rotation point and a radius of 4 cm in cephalad direction and 7 cm in a posterior direction. You may use a pretracheal incision or a retrotracheal incision with a hockey stick extension, a temporal extension, or something in between, which I prefer. You may encounter the superficial temporal artery here to be cauterized. The capsule is displayed, horizontally incised, and the lower part is resected together with a lateral ligament. The upper part is removed together with the remnants of the disc. And that exposes the condylar head. There is still tissue to be removed, medially soft tissue, but that will be done later. Vessels, very important. The medial extension of your reciprocating saw, your Lindemann drill or Fisher burr used for the condylectomy, should be gauged with reference to the mandibular nerve and the maxillary artery. The distance between the maxillary artery and the subcondylar region is only 6 mm on average, and sometimes it may be as short as 4 mm. Be careful. Do not section with your instruments, mechanically driven instruments, through the medial cortex. Just fracture the medial cortex. There is also the maxillary vein, branching of the retromandibular vein, to be considered, and the pterygoid plexus. Hence, be prepared for ligation of the carotid artery, the external carotid artery. Especially in ankylosis cases, I recommend to expose the external carotid artery via the submandibular incision and put a vessel loop in place in case a bleed from the maxillary artery cannot be stopped quickly enough. It's very important. When you check literature, it only happens in 1 out of 1,000 cases that such a bleeding cannot be stopped. This is life-threatening, colleagues. Okay, I use here a manual saw, but that's for the model surgery. In the hospital, I use, of course, a reciprocating saw. And I favor a high condylectomy before proceeding to the low condylectomy guided by the resection guide. I remove the upper part of the condylar head first. And why is that? Simply because access to the platform of the resection guide is facilitated by pushing the stump of your ascending ramus up into the fossa. Easier access to the platform of the resection guide. I like a horizontal osteotomy below the condylar neck and a vertical one posterior to the coronoid process. Others prefer one single oblique osteotomy. The condyle is removed and the medial part of the capsule as well. Yes, this may be tedious. I use a sharp instrument there because the capsule is made of silicone, I guess. In reality, I recommend you not to use such a sharp instrument, again because of the vicinity of the vessels. There is a lot of adherent fibrous tissue to be cleared from the fossa. Remember, this is end-stage disease, a lot of inflammation, maybe a couple of tissue-sparing surgeries before, a lot of scar tissue to be removed. You have to remove all of these soft tissues before you can try the dummy fossa. I found it useful to mallet the dummy the dummy fossa down into position. It clears any intervening soft tissue in a blunt fashion. If you don't do, you will find yourself struggling a lot with the titanium fossa component that is not fitting well, goes in and out, and in the meanwhile just attracts bacteria. So make sure that your dummy fossa fits perfectly well, and I recommend to use a mallet. Hammer it in. Then the question comes, what to insert first, the fossa component or the mandibular component? I prefer to insert the mandibular one first from the submandibular approach. So I can see the condylar head popping up from the temporal axis, and I see it in relationship with the fossa. I also can check if I can put it on the resection platform without intervening tissues, but I don't fix it. Next, I insert the fossa component. Remember, the mandibular component is not fixed, is in position but a little bit lower, which facilitates the insertion of the fossa component. Also, this one is screw fixed. And intermaxillary fixation is applied loosely. We need some leeway when we want to put the mandibular component back on top of the resection platform. So don't over tighten the IMF at this moment. The mandibular component is lifted onto the resection platform, and the initial screw holes, remember 3 screw holes of the resection guide, are retrieved and used again, this time after tightening the IMF. So once the mandibular component on the resection platform, the condyle nicely located within the polyethylene of the fossa, then perform your fixation. From the submandibular approach, but also from the temporal axis. Yes, I do pack autologous fat around the joint to prevent heterotopic ossification, although its efficacy is not scientifically proven. Don't forget, in the end, to reconstruct the pterygomasseteric sling and the platysma muscle. Suturing is over a radon drain without suction. So this is very simple, step by step explained the procedure. There are a lot of details and intricacies for which you may approach me later on by email, for example, or in your in the question box. But this is to show you that there is no magic about total joint replacement. The whole thing is to work in a very sterile way. Let's consider some indications. This was my last case of a free microvascular fibula transplantation. It was used to reconstruct part of the mandible after resection for a Ewing sarcoma. I used a stock TMJ prosthesis to avoid bony ankylosis in the TMJ. But today, I would reconstruct it all using an extended alloplastic TMJ prosthesis. It saves many hours of surgery and excludes the risk of flap failure. Today, I would keep the fibula as a backup, as a rescue procedure. Something else, unfortunately, they exist, these patients with obstructive sleep apnea due to condylar resorption after orthognathic surgery. Left before treatment, showing restriction of movements in 4D CT. The patient reported 10 for pain on a visual analog scale between 0 and 10. At the right-hand side, the renders of the planning. Customization allows to deal with the aesthetic aspect of the face as well, like the asymmetry in the lower jaw, which could be partially corrected by extra augmentation at the left-sided mandibular angle. Before, shortly after, and 3 years after surgical correction. The lady refused a chin advancement later on. And check here the limitation of the extra augmentation in the joint area. I think microlipofilling or a frank gluteal fat graft could be of help here, but she was happy. No pain at all. After 1 month, the visual analog scale dropped to 0, and she could resume normal life. A case done in my department, nicely performed for my colleagues, or by my colleagues indeed, but assume there is no radiotherapy involved. Would you still choose to do it this way? For example, a case of fibrous dysplasia in the left gonial angle. Reconstruction with iliac crest that unfortunately did not take. A case I did with Drs. Nicolescu and Dorobantu in Bucharest. Unfortunately, we could not offer her a dentition at the left side. But we work on a solution for that, which I cannot disclose at this moment. But here she is before, and I think 2 years or 3 years after the reconstruction. I hope I could teach you something. This is what I like to do. And we will be in touch in the future. Thank you again, and have a nice evening. Thank you.